TopMedTalk.
Well, hello and welcome to TopMedTalk. I'm Desiree Chappell. I'm host and managing editor of TopMedTalk, and I'm joined by our editor-in-chief, Monty Mythen. Hello, Monty.
Hey, Desiree. Having a great day so far?
Well, we've had the opportunity to catch up, as we do at these meetings, with some of the delegates and the presenters and speakers here at the meeting as well. And we've had the opportunity to do that again with our next guest, who is Evan Kharasch from Duke University. Evan, thank you so much for sitting down with us.
My pleasure to be here. Thank you for having me.
Yeah, so actually we also have Korey Springman, who is a perioperative medicine fellow at Duke. And she was talking to you earlier and asked you to come over and sit down with us. So I thought that was great that we'd have the opportunity to talk to you a little bit about what you're going to be presenting on during the meeting tomorrow. But there were a couple things we were able to chat about. We wanted to...
Yes, so first of all, Evan, I'd just like to say thank you for agreeing to be our Evidence-Based Perioperative Medicine International Plenary Lecturer this year. And we'll come back to the topic you're talking on in a moment. But also, thank you for your work as Editor-in-Chief of the world's premier anesthesia journal. Been in number one ranking, just reinforced as number one ranking. The BJA knocked them off for a short blip, but they recovered. So, Evan, tell us a little bit more about that role.
Well, I've been editor-in-chief for a little bit more than 2 years. Yeah. I served for 15 years on the editorial board of the journal. I served my terms of service, and when the editor position became available, several colleagues of mine came to me and said, we'd like you to apply for the job, and it had just so happened that my previous role in my university senior administration had ended, and I didn't know what was next, so it was very fortuitous that the what next presented itself. And being a lifelong academic, having served on the journal for a number of years, being very dedicated to the concept and the community of academic anesthesiology, the idea of leading the world's leading journal in the specialty was a very attractive one, and I was fortunate to have been chosen. And it's a spectacular job, if you will, but really it's an opportunity to work with spectacular individuals. I have a very, very talented and dedicated group of editors. Our mantra at the journal is increasing the richness and the reach of what we do. And we came out at the beginning of this year with a tagline for the journal because I wanted to express what we're about. And people would say, well, tell me what you're about, and I would go through a little bit of an explanation, but I wanted something that really encapsulated and captured what we're about in a short sentence. And we did a self-study process and did some interviews with authors and readers, and they kind of told us what they think we're about. And what we came up with was the phrase trusted evidence from discovery to practice.
Excellent.
And that discovery to practice really means two things. It means that our content spans the range from very basic science and discovery all the way through to clinical practice, both prospective and retrospective examinations, but also that we'd like to see the knowledge that we put out be translated from discovery to practice. And we're quite happy that we were able to encapsulate that goal and that value proposition to our readers. And interestingly now, when I get the journal every month and I do open it and read it, I look at the cover where it says trusted evidence, and I get a little intimidated because we've just raised the bar on ourselves even higher.
That's good, though. It's good to push, right?
It is good to push.
Yeah.
And Evan, I think I'm right in saying, although you're principally come from the USA as a journal, your association with the Society in America, but you're a global journal, and I think you've been trying to increase that global reach. Absolutely.
We've been trying to increase our international readership, our international contributorship. We have an editorial staff which is truly international, both at the senior editor level as well as the associate editor level. And we've also, this past 2 years since I became the editor, have started translating our monthly podcasts, which had been just in English. We're now doing them in Japanese, Mandarin Chinese, Portuguese, Spanish, and we just added French.
And that should. So why France in particular? I think not everyone understands why French language is so important for one sector of the world.
It's really it's our way of making ourselves available to a large number of practitioners in Africa, where French is a common second language, if you will. And so many French anesthesiologists do speak English. We may get some who only speak French, but the strategy there was really trying to reach an African readership as well.
And I listen to your podcast and have listened to your podcast. It's not somebody just reading the abstract and the paper out. It's a secondary exploration of the content.
That's correct. We write the script for the podcast specifically for the listenership, if you will, because we understand that the listened to language and the way that you take in information is very different than reading it in an abstract.
Yes.
So we put our information out to our readers in many different ways. We have the full articles, of course. We have article abstracts. We have something that is a summary box on the first page of the article, which says, what did we know before this article, and what does this article tell us that is new? And then we also have a short summary in the table of contents, and then also in the podcast. So we're trying to present information in as many ways as possible so that we can serve the audience that likes to take in information in different ways.
It sounds like the podcast is one of those ways that you're translating evidence into practice. Is that, I mean, do you take your podcast any step further into exploring, the clinical implications of utilizing the research that you're talking about?
That's we deliver the take-home message, if you will. And in the podcasts, we emphasize the clinical material that we do. The journal publishes about 2/3 of its content is in the realm of clinical medicine, and 1/3 is in basic science or so. But it's not pure basic science, if you will. We like to publish what we call clinically applicable, clinically relevant, or clinically foundational basic science. And that, because that's really our mission as a journal and our readership. Very often when we have basic science articles, we will have an editorial written to accompany that article, which essentially encapsulates the take-home message for clinicians. And then we've also added a new type of article in this past year that we call the Reader's Toolbox. And this is an article that comes from the challenge that many of our readers may not be familiar with some of the complex technical methods that underlie our research articles. And along the theme of increasing the reach, we thought that if people couldn't understand how the information was generated, they might not be interested in the article or might not be able to understand the article. So we've now come out with periodic articles that are really primers about some of the research methods. Some of the research methods have been developed since I trained, and many of our readers have trained, and we understand that we all participate in continuing medical education, but in some ways this is continuing research education.
Absolutely. It's gotten more and more complex. Even as a recent trainee, the research methods are very, very important when understanding and interpreting any type of data that comes out before applying it.
Well, I classify myself as pre-omic in my education. So it just about immunology was just sort of happening, and there was that we only understood DNA, but that omics wasn't a thing.
Not
and
at
now
all.
There's an omic for everything.
I trained back in the era of round peas and wrinkled peas, and that was the world of genetics.
So evidence-based perioperative medicine is what it says on the can. And, thank you very much for agreeing to do our plenary tomorrow, the EdPom International one, which is revisiting an old friend we'll ask you about in a moment. Now, there's been a lot of discussion about multimodal analgesia in the context of enhanced recovery after surgery and doing everything to get away from opiates. Not to abandon opiates completely, but to minimize opiate use. And I think what you're going to tell us about is about a forgotten friend, perhaps, in your lecture.
Right. This is the concept, and the friend that we're talking about is an opioid, methadone. And this is an opioid that people tend to associate with the treatment of opiate addiction, for example. But it's really an old opioid. It was developed in the 1940s, and it's a opioid with a very long duration of effect.
Now, if I may interrupt you, what was your background before you were a physician? I believe, were you not a pharmacist?
No.
I was. Oh, I'm so sorry.
I interlaced my medical school education with a PhD in pharmacology. So I am a clinical and basic pharmacologist. I have a clinical research team as well as a basic science program. And one of the reasons that I became an anesthesiologist was because I thought it was one of the best places in medicine for a clinical pharmacologist to be. Yeah. So I approach anesthesia as the everyday implementation of clinical pharmacology. And along those lines, I've developed a kind of thinking that we want to match the duration of effect of our analgesic drugs to the duration of pain. Acute postoperative pain is a problem. Surveys among patients have said that 75 to 85% of patients say that their acute postoperative pain was not adequately treated. The majority say that their pain was moderate to severe. We know that pain has significant untoward consequences. Chronic postoperative pain is a problem in 10 to 50% of patients. And the single biggest risk factor for chronic post-surgical pain is acute postoperative pain. Acute postoperative pain also increases the risk of complications like surgical site infections, urinary tract infections, and frankly, patient well-being and patient suffering. So the idea is, as you said, Monty, we really want to try and deliver optimal perioperative pain relief and analgesic care. And so methadone, in contrast to a trend that has developed in anesthesia over the course of the past few decades towards shorter and shorter and shorter duration drugs, the duration of pain hasn't gotten any shorter. It's only the duration of the drugs. And this is a little bit of a contrarian approach to say that if the pain is going to last a long time, let's use an opioid that lasts a long time.
Evan, do you use it as I know pre-meds have become very unfashionable, but when I was a child in anesthesia, we used to go around writing up Om and Scop, which was Omnipom, a morphine cocktail,
right,
and scopolamine as a drying agent because we were using gases that made you salivate.
Absolutely.
And the patients seemed to be pretty darn happy when they, although they were asleep when they often rolled into the operating room, they had analgesia on board.
Right. They were anesthetized before they were anesthetized.
So they started that just in the pre-op holding area?
They got an intramuscular injection on the floor.
Yeah. On the floor.
Yeah, so
yes.
They can't sign their consents now if they do that.
That's correct. That's correct.
So I'm not saying we go way back there, but
I was going to say that was the day some people came.
That segued into, which has probably turned out to be a bad idea, is giving people midazolam
Versed,
an anxiolytic that creates confusion, which doesn't provide pain relief. Where are you? When do you use it? How do you get it into the patient, and what sort of dose do you give?
In terms of I use it at induction,
yep.
and I'll do cases with any opioid that I happen to have available, but very often I'll do cases with methadone, and we give them a single dose at induction, and that's the only opioid they get for the entire case.
And an IV, and
IV,
how much do you usually give?
20 milligrams in inpatients, and now I'm talking only about adults. I've done a number of studies in children, but in collaboration with pediatric anesthetists. In adults, 20 milligrams at induction. For an inpatient, if it's a 23-hour overnight patient, we usually use 15 milligrams, and if it's a same-day discharge patient, we give 10 milligrams. And that's really the only opioid we use for the entire case. And then, of course, if they need more at the end of the case or they need more in the recovery room, we will give them additional bits of methadone before we send them home.
Now, methadone has a little bit different properties because it also works at the NMDA receptor as well as the, I believe...
U receptor.
Yeah, U receptor. And I thought there was another one, which makes sense when you think about inhibiting chronic pain or the development of chronic pain. I remember in residency, I was like, why don't we start using methadone early on when we know this patient is going to end up on chronic pain with chronic opioids because it does work at different receptors. Yes. And people scoffed at me initially, but it does have the pharmacological effects at other receptors, which is kind of what the whole goal is.
Correct.
In certain patients.
It in and of itself is a bit of a multimodal analgesic.
Yeah.
Because it's a mu opioid receptor agonist and it's an NMDA receptor antagonist. So in and of itself, it's a bit of a multimodal drug. The other aspect of it is that patients who get a single dose of methadone at induction use less opioid postoperatively.
That's what I was going to ask.
They also have less pain postoperatively. Mm-hmm. And this is among patients who have free access to PCA postoperatively. Yeah. They still say that their pain scores were less than patients who got a different opioid postoperatively. And we think it may be because of this multimodal nature of the drug by itself, as well as the fact that with a long-duration opioid, we have very sustained, even blood concentrations of the drug, which is very different than using repeated doses of short-duration drugs where you are cycling above an effective level and then dropping below an effective level and being in pain. So you stay above the effective level because it's slowly eliminated. You stay there at kind of a steady state for a long period of time.
And you're still combining with the acetaminophen and non-steroidals
Yes.
as indicated?
Yes.
But staying away from the gabapentinoids? Or?
I stay away from gabapentinoids.
I agree, I do as well.
And the reason is that I appreciate that the combination of opioids and sedative hypnotics is a risk space. It's a more dangerous combination. We learned decades ago that if we give small bits of an opioid, there's not a problem with respiratory depression. We give small bits of a sedative hypnotic or a benzodiazepine, and you don't see respiratory depression. But if you combine them, patients stop breathing. And so I encourage practitioners to really stay away from sedative hypnotics and benzodiazepines when used with opioids. And that's a generalized statement, but I also apply it to methadone because it's a long-lasting, long-duration drug. So I actively give patients acetaminophen and COX-2 inhibitors preoperatively, and I don't give gabapentinoids preoperatively. And I'll usually ask patients if they're nervous or anxious, and if they're not, then I don't give them benzodiazepines either.
Yeah. Now, flip side of the coin, right now we've heard lots of positives about methadone. Have you ever had patients that didn't respond as well and may have had more sedation, something that would be unexpected? We have rapid metabolizers and slow metabolizers. Have you seen this with using methadone in your practice?
With a single intravenous dose of methadone, I have not. Now, it's a little bit different when we get into using methadone for chronic pain, for example, because when it's used orally, some of the pharmacokinetic considerations are a little bit different. When it's used orally, some of these genetic considerations come into play. But with a single intravenous dose at induction, the genetic differences don't come into play. And when I have seen, and it's been sort of reported back to me on rare instances where patients have been sleepy, for example, it almost invariably turns out that there was the combination of sedative hypnotics with methadone.
Yeah.
And you would see that with any other opioid as well, but the duration may last a little bit longer because the duration of methadone lasted a little bit longer.
So I have two questions that I think a lot of practitioners would probably ask who are new to using or never used methadone in their practice. So one, you said you've reduced the amount of, if any, need for opioids post-operatively. If the patient does need them once they've been home, what is the choice usually then?
We don't tell surgeons to do anything differently as far as their post-operative pain prescribing. In fact, we don't even tell them what we've used during the course of the case.
Because we have an ongoing trial right now at Duke.
Correct.
That we're using, and we are not blinded as the anesthesiologists or the anesthesia providers. The patient's blinded, and I don't believe that we communicate that with the surgeon. So we continue to let them practice as they wish, and we just give the dose of methadone or other opioid. But
is anyone are any surgeons using methadone post-operatively, like once patients go home?
Not to my knowledge. That's a very different sort of approach and construct.
Yeah.
It's not one that I would recommend without some very intensive study.
Yeah. And then my second question was pre-operatively, like some of the physicians that I've worked with, we don't have IV methadone, and so they were just using oral methadone. So is that something that you've actually used but not prefer just because of the issues with it?
That's not anything that I've done.
Yeah.
One of the things about intravenous methadone is that the onset is very fast. Mm-hmm. The onset is about as fast as the onset of fentanyl, for example. But with oral methadone, the peak of the absorption is at about 4 hours.
Okay.
So you'd need to be giving it pretty far in advance of surgery in order to get the effect that you're looking for. And if you're looking at short cases, the majority of the effect is now going to be post-operatively as opposed to intraoperatively.
Yeah.
So
you're using it as your primary source of pain control during analgesia.
During the surgery and afterwards as well. And we'll use it in the recovery room as well, 1 to 2 milligrams at a time until a patient is comfortable, in the same way that we've conventionally used hydromorphone or fentanyl in the recovery room as well.
Any red flags, any idiosyncratic reactions at the time of injecting it, or anything we should be? No.
I haven't experienced anything in my practice with it, and we use it quite frequently, or at Duke we have.
And any patients that we should be concerned about using it in, that a patient that you would not use it in? I mean, other than an allergy.
I generally am cautious in patients that have hepatic insufficiency or renal insufficiency, simply because it hasn't been well studied in those patients. But that's really the major group in which I will avoid it.
And the prolongation with the QTC really only happens with multiple different doses. It's more stacking, not just a single dose. So those patients you really don't have to exclude, from what I understand about methadone.
Correct. Methadone can prolong the QT interval, but the median dose at which it prolongs the QT interval is greater than 400 milligrams. We're using it in a dose range of 10 to 20 milligrams.
Yeah, one time.
So we don't worry about QT effects at all.
So if I was a practitioner whose practice traditionally was maybe a little bit of fentanyl around the time of induction of anesthesia, followed by a little bit of morphine during the case to give a lingering effect, I could switch that out for my single injection of methadone and get to a similar place intraoperatively, but have this long tail of benefit.
Correct.
Great.
And one more question, just because I can think of what people would be asking, especially with the multimodal. A lot of people are trying to get rid of opioids in general. I think some people would think methadone is not necessarily in the same category.
Right, it's the total opposite. But
I think Tylenol, NSAIDs, but ketamine is huge right now, and especially in the OR. And so, have you looked at methadone with ketamine, or any looking at the effects or multiple effects of that?
We have not. There may be people who may use them together.
Yeah.
Understand that ketamine is an NMDA receptor antagonist. Morphine is an NMDA receptor antagonist. I'm not sure how much additional benefit you would enjoy combining ketamine with methadone, but I don't perceive that there would be an untoward drug interaction, for example.
No, and I believe IV ketamine is pretty short-acting. So I don't think...
And Evan, where do you stand? Another fashion, IV lidocaine. Where do you stand on IV lidocaine?
Yeah, I think that
I mean, a lot of these fashions are uncontaminated by substantial data.
They are unimpeded by the thought process. Yes,
I mean they're rational, many of them, but
they are rational. Yeah. They are logical, and they are largely untested.
Yeah. Yes.
So they fall into the category of it seems like a good thing to do. It may be. And those things that have minimal downside risk, but they seem like they may be good to do, tend to be used. And so the data on lidocaine is a little bit spotty. We published a review article on it a year or so ago, and the literature to suggest benefit was a little bit spotty. Some studies suggested that there was benefit, others suggested not. I don't know if that means that it's procedure specific or it means that the marginal benefit is relatively low. And I think it also depends on what else is in your recipe, if you will. And we know that lidocaine is effective. You may know that you can do a total intravenous anesthetic with lidocaine. It's an old South American technique, which we don't do anymore today. But it works quite well.
Work, yeah.
So I think that there's really minimal downside to lidocaine infusions during the case. I don't know that they've been studied in combination, let's say, with or without opioids or with or without methadone.
And there are some. Mechanistically, they're preclinical studies to suggest the fact that it may have an impact on tumour cells. It's speculative.
Yes, I mean there's a great many laboratory studies now that have been looking at the influence of various drugs and conditions on tumor cells, and those models vary. Sometimes they are primary cells, sometimes they're immortalized cells. Immortalized cells behave differently than primary cells. Some have looked at very high concentrations of drugs. Some have looked at more therapeutic or pharmacologic or representative concentrations of drugs. I think it's an area of active exploration. I don't think it's one that we would call settled science. And certainly with regard to what we do clinically, there's great interest. But I think it's an area of more unknown than known at this point.
I think there are some big trials in the pipeline, some very large trials in the pipeline. I think if you look on clinicaltrials.gov and similar, you'll find that there are some large pragmatic trials kicking off, which is going to take a number of years to settle that, but good news that they're happening.
Yeah, that is good. We definitely need to do that because I think a lot of people are utilizing some of these things. Want in the interest of doing multimodal and maybe not all
thinking that it makes sense, but really not understanding everything.
Yeah. So, and put in the hands whenever you're not familiar with it and not familiar, it's sometimes a little dangerous.
Right.
So.
We also have an interesting phenomenon where when new things are tried in anesthesia, they tend to focus on the positive benefits, but don't always look at potential risks. And sometimes it isn't until later that we appreciate that we may be perceiving advantage and thinking there's no disadvantage when in reality there may be disadvantage. And technically, when we talk about multimodal approaches, the whole idea is that we're going to get additivity of benefit without equal additivity of side effects. Or we're going to get synergy of benefit, but only additivity of side effects. That is, the gain exceeds the possible risks involved. And sometimes that's borne out when we look at it, and sometimes when we look at it carefully, we find out that we have just as much side effect baggage, if you will, as benefit. And that, for example, is one of the things we learned with gabapentinoids.
That's exactly what I was going to say. That really has been the first time in my career I've been out for about 10 or 11 years that I've seen the swing of the pendulum, where it was the uptake and everybody's using gabapentin, and so many people are walking that back. now and have seen the side effects, and it's like we can't add that into our multimodal pain management schematic. They take it out or reduce doses. And then actually kind of the same with the lidocaine too, that they've seen a lot of issues with that as well in practice. So it's interesting to kind of see those swings.
I've been many years ago.
Many more for us.
Yeah.
Many years ago, I wrote an editorial in Anesthesiology about the concept of fashion in clinical practice. Yeah. And ties get wide and ties get narrows. And
legs on pants.
Yes.
Hemlines go up and hemlines go down, and drugs come into favor and drugs go out of favor.
Yeah.
And what's new is old, and what's old is new again. And in some ways, that's how we learn.
You're right. Not to be absolute about anything. I mean, keep an open mind and do our best with what best knowledge is known at that time.
I think that in anesthesiology, we went through an era a couple of decades ago where we often saw at least one new drug introduced into the specialty every year. And that has really changed in the past decade. So I think that some of the focus has changed from evaluating new pharmacology to looking at new ways to combine existing pharmacology.
I will say my favorite latest drug that's come out is dexmedetomidine. And I use that drug, that multimodal, a lot.
Is that really new, though?
It's not too new, but I would say within anesthesia it's coming...
Well, it's definitely in fashion right now.
It is definitely in fashion. The drug was developed about 20 some odd years ago.
Yeah,
it was developed by a company in Finland called Pharmos.
Yes.
And then it was in-licensed to the States and then internationally by Abbott. And they worked for many years trying to get it introduced. They started in the critical care arena, and then within the past few years, it sort of caught on in a sense.
It's again the multimodal thing, I think.
In perioperative, and I think it's been stimulated by a couple of things. One is the emphasis on enhanced recovery.
Yep.
Another is the emphasis on multimodal. But it is a sedative hypnotic as well as being an analgesic. It is a multimodal drug. I was involved in some of the early work and explorations with it. And it's interesting because in the world of drug development, and I've worked with a number of companies, you want to have a drug with as narrow a pharmacology as possible, and that's your indication. And any other effects are what we call off-target, and they may be side effects. And the very unusual thing about dexmedetomidine is that it has many effects all at the same dose.
Yes.
And we used to have conversations to ask the question, which of those is going to be your indication and which of those is going to be your side effect? So it is a very different drug in that sense, where you have a multitude of pharmacologic effects all at the same dose. So you do get some analgesia, you do get some anxiolysis, you do get some sedation, and then it's how you're going to incorporate those many effects into the anesthetic that you're going to deliver.
So to date mark a little bit, I took over as the PI for a DEX study at Duke 24 years ago in phase 2. So that means you'd already been at it for quite a long time by the time we got to phase 2.
I believe one of our current instructors at Duke now, who trained in the UK, said that they got to use it within a trial, but then it was taken away and they could no longer get it here in the UK.
It's not about the money.
It's about the money.
Saul Aronson.
It's not about the money.
Well, we should. I know you're going to make us. I just want to give a plug.
Okay.
Give a plug. So your podcasts are within the journal website, but they're open access.
Yes.
Our podcasts are accessible from the journal website. They are open access. They are freely available to anybody. You don't have to be a subscriber, and we also archive them. So that you can go back and listen to any previous podcast.
And that's, just to be clear, that's the journal Anesthesiology spelt without the A.
Absolutely.
The right way.
Anesthesiology.org.
The world's premier journal.
We invite people to read and to listen.
Yeah, that's great. Well, Evan, thank you so much.
Thank you very
for sitting down with us. And I hope we can do this again sometime soon.
Thank you.
Cheers. All right. Well, thanks for listening. Cheers.
TopMedTalk.
Nate Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out TopMedTalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. TopMedTalk.com, and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.